Hello folks, I welcome you to this new session in which we will discuss about ocular trauma. Hi, I'm Dr. Rashmi Malhotra and I'm Assistant Professor in Department of Ophthalmology. In this session, we'll learn how to take good history in a case of ocular trauma, to understand the effects of trauma on the eye, to understand the management of eye trauma, and to understand the basic terms related to eye trauma. We all know that eye is well protected by the bony orbit, but it yet may be subjected to many kind of injuries like foreign bodies, blunt trauma, penetrating trauma, and chemical and radiation injuries. Ocular injuries are more common in males, in children and young. In certain occupations, injuries are more prone like construction and industry, like in sports, boxing, and outdoor activities, and motor vehicle accidents. Eye injury can be classified into either open globe injury or closed globe injury. Under closed globe injury, it can be either lamellar laceration, which is a partial thickness wound to the eye wall, or it can be contusion, that is a blow to eye wall causing partial thickness wound. Whereas in open globe injury, which is a full thickness wound to the eyeball, it can be either a laceration or it can be a rupture. Laceration is full thickness wound of eyeball by a sharp object when a sharp object is used. Whereas a rupture is when there is a full thickness wound of eyeball with a blunt object. Then laceration can also be associated with intraocular foreign bodies, a penetrating injury, that is, there is an entrance wound but no exit wound, whereas a perforation is when there is an entry and an exit wound. Eye injury may present as closed globe injury or a non-penetrating trauma in which the eye globe is intact, but there is intraocular damage. It can either be a contusion, that is a blunt trauma, where damage can be at the site of impact or at a distant site. Or it can be a lamellar laceration, that is a partial thickness wound caused by a sharp object or a blunt trauma. Then there can be a penetrating trauma. That is, the globe integrity is disrupted by a full thickness entry wound. It may be associated with prolapse of intraocular contents of the eye, like iris, lens, or vitreous. Then there can be blowout fracture of the orbit, which is generally caused by blunt trauma. Fist or ball injury is the main culprit. It leads to fracture of the floor or the medial wall of the orbit due to sudden increased pressure on the orbital contents. Then there can be perforating trauma, that is, the globe integrity is disrupted in two places. There is an entrance wound and there is an exit wound, that is through and through injury. It is the severest type of injury. Always remember, penetrating injury is the one where there is only entrance wound. Perforating injury is where there is an entrance wound and an exit wound. Perforating trauma is one of the severest type of eye injury. Now let's start with blunt trauma first. The blunt impact may damage the structures at the front of the eye or at the back of the eye. If it is a trauma by a small object, the brunt is taken by the eye itself. But when a large object like football or fist is involved, the most impact is usually taken by the orbit margin, which may lead to a blowout fracture. The blunt trauma of the eyeball produces damage by different forces. First is direct impact on the globe. That is, it produces damage at the point where the blow is received. Then it can be either compression wave force. That is, it is transmitted through the fluid contents in all the directions. It may cause considerable damage. Sometimes the maximum damage may be produced at a point distant from the actual place of impact. This is known as contre-coup damage. Then it can be in the form of reflected compression wave force. That is, after striking the outer coats, the compression waves are reflected towards the posterior pole and may cause foveal damage. Then it can be rebound compression wave force. That is, after striking the posterior wall of the globe, the compression waves are rebounded back interiorly. And then there can be indirect force, where the ocular damage may also be caused by indirect forces from bony walls and the elastic contents of the orbit when the globe suddenly strikes against these structures. Here are the different mechanisms in which the blunt trauma can affect the eyeball. There can be different modes of damage, like mechanical tearing of the tissues of the eyeball, damage to the tissue cells sufficient to cause disruption of their physiological activity, vascular damage like ischemia, edema, or hemorrhages, trophic changes like disturbances of the nerve supply, and delayed complications like secondary glaucoma, late rosette cataract, or retinal detachment. The traumatic lesions of blunt trauma can be described as either closed globe injury, globe rupture, or extraocular lesions. Closed globe injury can present in various forms like subconjunctival hemorrhage, which is bleeding underneath the conjunctiva. Small fragile conjunctival blood vessels are easily ruptured. The blood leaks into the space between conjunctiva and sclera. The symptoms are red eye, mild irritation, and patients are usually asymptomatic. Patients with subconjunctival hemorrhage generally do not have any symptoms except for mild irritation or presence of redness of the eye. On examination, we can notice blood underneath the conjunctiva, which is often sectoral. Sometimes the entire view of sclera may be obstructed by the blood. A proper workup is important along with thorough history, which should rule out any bleeding or clotting problems, history of any medications like aspirin or warfarin, eye rubbing, trauma, heavy lifting, recurrent subconjunctival hemorrhage. Specifically, in case of recurrent subconjunctival hemorrhage, we should always check vitals to rule out hypertension. Bleeding time, PT, PTT, and CBC should always be checked. Generally, reassurance is enough. Patients do not require any medications except for lubricants. Closed globe injury may also present with corneal abrasion, which is the breach of epithelium, and it stains well with fluorescence. It heals within 24 hours with pad and bandage after instilling antibiotic ointment. The closed globe injury may also present as traumatic hyphema. Now, traumatic hyphema is very important both in view of your PG, NEET PG, and your final exams. It is the hemorrhage in the anterior chamber. The source of bleeding is generally the iris root or ciliary body phase. The total hyphema is known as 8-ball hyphema. The treatment is aimed at prevention of secondary hemorrhage and control of elevation of IOP and staining of the cornea, which can be blinding. Again, a thorough history is very important regarding the type of injury sustained, personal or family history of bleeding disorders, drug intake in recent past, specifically NSAIDs and aspirin, history of similar episodes in the recent past. A thorough examination of hyphema patient is of utmost importance. We should also consider ruptured globe in a suspected case. Vision is of utmost importance. Size of hyphema, clotted or whether it's a fresh blood is also important. We should always check for intraocular pressure. Corneal blood staining. If there is corneal blood staining, it means the trauma or the hyphema is old. Gonioscopy should always be done at 1 month post-injury. Ultrasonography should be done to rule out any posterior segment injury, including vitreous hemorrhage or retinal detachment. Laboratory tests like hemoglobin electrophoresis may also be important in case of recurrent hyphema. The treatment of hyphema involves complete bed rest with head elevation up to 30 degrees, eye shield to protect the eyeball, control of systemic blood pressure specifically in case of recurrent hyphema cases. Medical management involves atropine 1% eye drop for cycloplegia. This will manage the pain also. Topical steroids, anti-glaucoma medications, and laxatives, specifically laxatives because this will avoid strain which may lead to recurrent hyphema. NSAIDs should be avoided for pain. If required, paracetamol can be given. Now this is important. When do these patients require surgical drainage? A surgical drainage of hyphema should be done if the IOP is more than 50 millimeter of mercury for 5 days, or if the pressure is more than 35 millimeter of mercury for 7 days, or at the earliest sign of blood staining, or if the IOP is more than 25 millimeter for 5 days in total or near total hyphema, even after maximum medical management. Then is the rosette-shaped cataract, which is a common sequel of blunt trauma. The postulated mechanisms are direct damage to the lens fibers, minute ruptures in the lens capsule with an influx of aqueous, hydration of lens fibers and consequent opacification, ring-shaped anterior subcapsular opacity, which is known as Voysey's ring. It occurs due to striking of the contracted pupillary margins against the crystalline lens, which forms a flower-shaped cataract or opacity, which is also known as rosette. Opacification occurs in the posterior subcapsular cortex along with posterior sutures. These opacities may subsequently disappear or remain stationary or progress to maturity. In case of visually significant opacity or cataract, a proper cataract surgery with IOL implantation is required. Another sequelae of blunt trauma is commotio retina, which is caused by the concussion injury to the sensory retina. It's a cloudy swelling that gives rise to grayish appearance to the retina, generally affects the temporal fundus. If it involves the macula, it is known as Berlin's edema. In case of macular involvement, the choroid vasculature through fovea shows and looks like cherry red spot. So in severe cases, it may be associated with intraretinal hemorrhages that can involve the macula. Generally, in mild cases, the prognosis is good with spontaneous resolution in around 6 weeks. But in complicated or severe cases, it may lead to progressive pigmentary degeneration or macular hole formation. Now let's talk about foreign bodies. The corneal foreign body is a foreign body material on or in the cornea. It can be either metal, glass, or organic material. When there is a foreign body on ocular surface, patient generally presents with foreign body sensation, tearing, photophobia, pain, and red eye. On examination, the corneal foreign body may be present with or without rustring. There can be edema of lids, conjunctiva, and cornea. Foreign body can cause infection or sometimes lead to tissue necrosis. In any case of trauma, a proper thorough history should be taken. Visual acuity should be documented. 1 or 2 drops of topical anesthesia may be required to control pain and photophobia. A slit lamp examination should be done to rule out any perforation. Avert the eyelids and inspect for foreign bodies. Dilate the eye and examination of vitreous and retina should be done to rule out any vitreous hemorrhage or retinal detachment. For treatment, apply a topical anesthesia and remove the foreign body with spud or forceps at a slit lamp. If multiple superficial foreign bodies are present, it is easier to remove with irrigation. Always remove the rustring, which may require an ophthalmic drill. Measure the size of resultant corneal epithelial defect. Treat it as corneal abrasion. Pad patch should be applied with antibiotic eye ointment for 24 to 48 hours. Later, antibiotic eye drops can be instilled 3 to 4 times a day for about a week. These kind of foreign bodies are generally more common with industrial workers, agricultural workers, or builders. In such patients, eye health care education should be imparted. Now let's talk about intraocular foreign bodies. They traumatize the eye mechanically, they introduce infection, or can exert other toxic effects on the intraocular structures. It can be located anywhere in the anterior or posterior segments or angles. Foreign bodies of more than 2 mm can lead to extensive damage. Even a foreign body more than 2 mm can lead to extensive damage. Remember this. Modes of damage can be either mechanical effects, introduction of infection, reaction of foreign bodies, post-traumatic iridocyclitis, or even sympathetic ophthalmitis. The traumatic lesions may depend upon the route of entry, the site at which the foreign body is lodged. It can lead to either corneal or scleral perforation, hyphema or iris hole. They may lead to rupture of the lens or traumatic cataract, vitreous hemorrhage or degeneration, choroidal perforation, hemorrhage or inflammation, or can lead to retinal hole, hemorrhages, edema, or retinal detachment. There can be different types of foreign bodies. Glass, many plastics, and gold are generally inert. Iron foreign bodies can lead to siderosis. Copper can lead to chalcosis. Stones and organic foreign bodies can lead to infection. A complete workup is of utmost importance in a case of intraocular foreign body. First of all, a thorough history is required to understand the origin and nature of the foreign body material. A proper examination should be done to identify the possible sites of entry or exit wound. Topical fluorescein to identify the entry wound. If it can be done under minimized pressure on the eye, then gonioscopy and fundoscopy should be done. Associated signs such as lid laceration or anterior segment damage should also be assessed. It's always better to avoid gonioscopy and fundoscopy for later. CT scan with axial and coronal view should be done to localize the foreign body. Always remember, in case of metallic intraocular foreign body, MRI is contraindicated. Never do MRI in case of metallic intraocular foreign body. In treatment, intraocular foreign body should always be removed, except if it is inert and is not creating any harm. Tetanus toxoid should always be given. The entry wound has to be repaired, and infection prophylaxis, that is antibiotics, should be given. In anterior chamber, the foreign body can be removed by corresponding corneal incision. If the foreign body is entangled in the iris, should be removed by performing sectoral iridectomy. A magnetic removal of iron foreign body can be done. This involves creation of sclerotomy adjacent to the foreign body with application of a magnet followed by cryotherapy to the retinal break. Forceps removal may be used in non-magnetic foreign bodies through pars plana vitrectomy. Now let's discuss certain important intraocular foreign bodies that can cause reaction, like siderosis bulbi. The degenerative changes produced by iron foreign body is known as siderosis bulbi. It can occur after 2 months to 2 years. Steel is the most common foreign body constituent. The ferrous component undergoes dissociation and deposits in the intraocular epithelial structures. It always involves the epithelial structures like lens epithelium, iris, ciliary body epithelium, and sensory retina. On examination, the lens shows rusty deposits that are arranged radially in a ring. Iris becomes reddish brown. The retina, pigmentary degeneration occurs, which resembles retinitis pigmentosa. Secondary open-angle type of glaucoma can occur due to degenerative changes at the trabecular meshwork level. Then there is calcosis. It refers to specific changes produced by the alloy of the copper in the eye. The intraocular foreign body with high copper content can lead to a violent endophthalmitis-like picture with progression to phthisis bulbi. The copper dissociates and deposits in the basement membranes of the eye, like Descemet's membrane. On examination, it may present as Kessler-Fleischer ring at the level of Descemet's membrane, sunflower cataract at the level of lens, and retina may show metallic sheen. Now let's discuss a very important topic, chemical burns. The chemical injuries can range from trivial to potentially blinding. Mostly are accidental but can be assault also. Two-thirds of these kind of injuries occur as occupational injuries or at work. Alkalis penetrate more deeply than acids, as acids coagulate the surface proteins and form a protective layer. The most common alkalis involved are ammonia, sodium hydroxide, and lime. Ammonia and sodium hydroxide characteristically produce severe damage because of rapid penetration. The most common acids causing injuries are hydrofluoric acid because of its rapid penetration in ocular tissues. Sulfuric acids are mostly used in car batteries because of car battery explosion, because of high velocity impacts and thermal effects. It can lead to further complications. Alkalis generally dissociate and saponify the fatty acids in the cell membrane, destroys the structure of cell membranes of the tissues. It extracts the water from the cells and leads to total necrosis. The combination of lipids of the cells to form they combine the lipids of the cells to form soluble compounds which produce a condition of softening and gelatinization. Because of these, they penetrate deeper and cause extensive injury. Whereas in case of acid burns, the acid causes instant coagulation of all the proteins which act as barrier and prevent deeper penetration of the acids into the tissues. The Roper-Hall classification is used to prognosticate chemical burns. It is mainly based on cornea clarity and presence or absence of limbal ischemia. In grade 1, the prognosis is excellent because the cornea is clear and there is no limbal ischemia. In grade 2, still the prognosis is good because the cornea is hazy, still the iris details are visible and limbal ischemia is less than 180 degrees. From grade 3, the prognosis become more and more guarded as the cornea becomes hazy with no iris details and the limbal ischemia increases. The worst is grade 4 chemical injuries because the cornea becomes opaque, limbal ischemia occurs more than 70 degrees. Such patients generally result in such cases, the injury generally results in presence of symblepharon, severe dry eyes, conjunctival fibrosis, and permanent corneal opacities. There is another new classification, also known as Dua's classification of ocular surface burns, which is mainly based on presence or absence of limbal involvement or conjunctival involvement. As the limbus involvement increases by clock hours and the conjunctival involvement increases in percentage, the prognosis becomes more and more poorer. The treatment involves immediate and thorough wash of the with available clean water or saline, chemical neutralization of acid burns with weak alkaline solutions like sodium bicarbonate, or alkali burns with weak acidic solutions like boric acid mix, or EDTA 1% can be used. The mechanical removal of contaminants should be done. There should be application of topical atropine, corticosteroids, and antibiotics. Prevention of symblepharon can be done by using glass shell or sweeping of glass rod in phonesis twice daily along with antibiotic ointment. Treatment of complications like secondary glaucoma should be treated with anti-glaucoma medications. Corneal opacity should be treated with keratoplasties, and symblepharon should be treated with amniotic membrane grafting. But overall prognosis of severe chemical injuries is generally poor because of corneal opacities, severe dry eyes, and conjunctival fibrosis. And now let's discuss the final sequelae of penetrating injuries, that is sympathetic ophthalmitis. It is a bilateral granulomatous panuveitis occurring after penetrating trauma. Uveal prolapse is generally a feature of these kind of traumas. Following the intraocular surgery, usually multiple VR surgeries can also present with sympathetic ophthalmitis. The injured eye is called as exciting eye, whereas the fellow eye, which also develops uveitis, is called sympathizing eye. The incidence of sympathetic ophthalmitis has tremendously decreased in recent years due to meticulous repair of the injured eye. The sympathetic ophthalmitis can occur between 2 weeks to 3 months after the initial injury in 65% of the cases. Right now, the incidence is 0.2 to 0.5% after injury and 0.01% following intraocular surgeries. The etiology is not exactly known, but the predisposing factors are almost always it follows up penetrating injuries, wounds in the ciliary region, which is also known as dangerous zone, wounds with incarceration of iris and ciliary body. It is more common in children than in adults, and it does not occur when actual suppuration develops in the injured eye. So if the infection occurs in the injured eye, surprisingly, sympathetic ophthalmitis does not occur. So in the penetrating injury with uveal prolapse, the uveal pigment acts as an allergen and excites a plastic uveitis in the sound eye. Basically, it leads to activation of CD4 plus helper T cells, which lead to onset of this plastic uveitis. There is a nodular aggregation of lymphocytes, plasma cells, epithelioid cells, and giant cells scattered throughout the uveal tract, which leads to presence of Dehlen-Fuchs nodules, that is granulomas located between the Bruch's membrane and the retinal pigment epithelium, and sympathetic perivasculitis, that is perivascular cell infiltration on the retina. Now coming to the clinical features, in the exciting eye or the injured eye, there is a persistent low-grade plastic uveitis with ciliary congestion, lacrimation, tenderness, and keretic precipitates. Whereas in the sympathetic eye, that is sound eye, the involvement occurs in 4 to 8 weeks post-injury. It manifests as acute plastic iridocyclitis. Photophobia and weakening of accommodation, that is difficulty in near vision, is the first symptom. Whereas the first sign is retrolental flare and cells and a few keretic precipitates. Then there is ciliary congestion, slight tenderness of the globe, fine vitreous haze, disc edema, and sometimes cream-colored round choroidal lesions, that is choroiditis. Under treatment, let's discuss prophylaxis first. If there is no chance of saving the traumatized eye or it is a badly traumatized eye, better that eye should undergo evisceration. If the eye can be saved, a meticulous repair should be done, taking care of the iris and the choroidal tissue. It should be followed by immediate treatment with topical and systemic steroids and antibiotics along with topical atropine. If uveitis is not controlled even after 2 weeks, this eye should also undergo evisceration to save the other eye. Now, if unfortunately sympathetic ophthalmitis develops, if the patient presents shortly after the onset of inflammation, and if the injured eye has no useful vision, immediately perform evisceration. But if patient presents a bit later, a conservative treatment of sympathetic ophthalmitis should be done with corticosteroids, which should be administered by all the routes. In severe cases, immunosuppressant drugs should be started without delay. Topical atropine should be instilled 3 times a day. Overall prognosis, if intervened early, the vision can be saved. But in advanced cases, generally the prognosis is poor. I hope you learned something about ocular trauma today. I'll see you in another session. Till then, take care. Thank you.